Good morning, everyone. A warm welcome from the Department of Surgical Enterology to all the esteemed faculty members and my dear colleagues. Today we'll be presenting a case from the Department of Surgical Enterology which has pathological and medical relevance. So coming to the history, the patient is a 50-year-old female. She was a housewife from Thakurdwara in Uttar Pradesh. She presented to us in a OPD with complaints of pain abdomen for 3 months. The patient came to us. She was apparently asymptomatic 3 months before when she started developing right upper quadrant pain, moderate to severe intensity, intermittent episodes which was lasting for 30 to 40 minutes, and it was relieved on oral analysis. She did not give any history of radiation or referral of pain. There was no aggravating or relieving factors. She did not have any complaints of similar episodes in the past. She also did not give history of jaundice, loss of weight or loss of appetite. There was also no history of vomiting, altered bowel habits or fever. There was no history of abdominal mass. For the same complaint, she was evaluated at a private hospital 3 months ago, and she underwent an ultrasound examination, and she was informed to have a gallstone disease. So over there, she was further evaluated with routine blood investigations, and then she underwent a lab cholecystectomy, which was attempted on 31st of September 2022. In view of dense sedations, in the entire procedure was converted to open. However, the surgery was abandoned due to gallbladder mass with adhesion after 1.5 hours. Patient attendance was informed regarding the possibility of malignancy. No documents were available regarding the procedure. The patient was discharged on postoperative day 6. Drain was removed on postoperative day 3. Patient was discharged on postoperative day 6, and patient was referred to higher center for further management. She is a known case of type 2 diabetes mellitus for 8 years. She is on metformin 1 gram twice daily, and is a known case of hypertension for 5 years. She is on irregular medications for the same. She underwent hysterectomy 10 years back for fibroids. Postoperative course was uneventful, and she was discharged on postoperative day 5. She consumes mixed diet. She does not have any addictions, and she does not have any significant family history. She is married. She was married for 35 years. She is a para-2 with 2 living issues. Normal vaginal delivery that was conducted at home. Coming to the examination part, patient was conscious, oriented to time, place, and person. There was no pallor, icterus, pedal edema, or generalized lymphadenopathy. She was moderately built and well nourished with a BMI of 22.3 kg per meter square. Her performance status is WHO PS1 score. She had no signs of dehydration. Coming to the vitals, pulse rate is 72 per minute. BP was on the little the higher side with a BP of 130 by 90 mm Hg and respiratory rate of 16. On inspection of the abdomen was flat, umbilicus was central in position and inverted. There was 2 scars that was present on inspection. One was a right subcostal oblique scar of approximately 15 cm, healed by primary intention. Other was the lower abdominal phalangeal scar of around 8 cm, healed by primary intention. There were no other sinuses, peristalsis, skin nodule or engorged veins, hernial orifices. There was no visible cuff impulses. On palpation, there was mild tenderness present in the right upper quadrant. Abdomen was soft. There was no hepatosplenomegaly or no other palpable masses. Hernial situs, there was no palpable cuff impulse. On percussion, the liver span was 13 cm and bowel sounds were normal. Digital Excel examination was within normal limits. There was no abnormal findings. The other system examinations, respiratory systems, CVS and CNS were within normal limits. Coming to the case summary, so over here we have a 50-year-old housewife who is a known case of type 2 diabetes mellitus and hypertension, presented to us with right upper quadrant pain for 3 months with no history of jaundice, loss of appetite or loss of weight. She had attempted cholecystectomy outside. Surgery was abandoned due to suspicious gallbladder mass with adhesion, and on examination there were scars of previous surgery. So at this point, what are the differential diagnoses that we have? Anybody from the audience would like to give any differentials at this point? Sir.
So I know the diagnosis of this case, so I will not be disclosing that. So apparently we have a 50-60-year-old female with a suspicion of GB mass intraoperatively. So for all practical purposes, my first diagnosis will be incidentally detected malignancy of GB. I think there should be no doubt about that. That 99% of such cases will be gallbladder cancer. Second possibility, because this is a CPC which is being presented, maybe in India tuberculosis may be important, but GB tuberculosis is a rare condition, but it's being presented in CPC, so I'd like to keep a possibility of tuberculosis of gallbladder. And third could be a porcelain gallbladder kind of thing, but it would have been already detected on ultrasound, so which we have not found. So I'll keep these three possibilities.
You didn't tell us about the tumor marker status that you'll be
We'll be telling.
okay, because we need the tumor marker status also to come to some differential diagnosis.
Actually, just a point to ponder that incidentally detected CA gallbladder, we say when you send the gallbladder for histopathological examination and pathologists tell us that it is, so neither we had clinical suspicion nor we had radiological or imaging suspicion. So that's the definition of incidental CHEB. One more entity, I think in this era and in this region, we are operating more and more such cases who are coming to us with GB mass. Nirjan will agree with me that actually on biopsy they turn out to be IgG4 cholecystitis. They can present as lump, palpable lump in the right hypochondrium. And of course, as you said, GB tuberculosis. So GB tuberculosis primarily in the wall of the gallbladder is extremely rare. Most of the GB tuberculosis they present as tuberculosis in the cystic lymph node of Lund or tuberculosis in the paracholedochal lymph nodes or paracholedochal lymphatics. So in the wall, if patient is having GB tuberculosis, it's extremely rare. However, we have operated 10 such cases here successfully of GB tuberculosis, and we have published that series also. Right, but in this endemic belt, if such and such patient is presenting, if the tumor markers are inconclusive, and so far no tumor markers is very specific to GB carcinoma, so don't go for tumor markers. Many times we have witnessed that tumor markers were absolutely normal, they were in fact below normal values, but patient had metastatic carcinoma gallbladder. So it can happen.
Just for the people who have recently joined, just can you go back to the summary of the slide?
Yes.
Just put that.
So this is the 50-year-old with a well-preserved patient with a short history without an appetite loss and weight loss, and the abdomen is closed due to dense adhesions and some mass. So definitely the first diagnosis comes in mind that the malignancy, but we cannot ignore the other facts like relatively young well-preserved patient and all these things. So we should definitely think that some unusual diagnosis like Rohit sir told and sir told that tuberculosis. And one more thing, what I observed that xanthogranulomatous cholecystitis, whenever that comes in picture, there is dense adhesion, and most of the time these kind of patient, they just reported there is dense adhesion and abdomen is explored and immediately it closed. When some malignancy is there, they are reported like, there was malignancy. Out of the, when we talk the surgeon, they tell there was some malignancy. But I feel that whenever some inflammatory, some other conditions are there, there will be very dense adhesions. And the surgeon report, some mass was there and some dense adhesions were there. So in these kind of picture, when history and this exploration findings are not like kind of this, so we should think about out of the box also.
Thank you everyone for the valuable input. So at present we have a 50-year-old female who is a housewife, came with complaints of diabetes mellitus and hypertension. This is a short recap for people who are joined just now. So we have a 50-year-old housewife, in one case of type 2 diabetes mellitus and hypertension, presented with right upper quadrant pain for 3 months without any history of jaundice or loss of appetite or loss of weight. She has undergone attempted cholecystectomy outside and surgery was abandoned due to a suspicious gallbladder mass with adhesion. On examination, there was cause of previous surgery. So coming to the differential diagnosis, so the differential diagnosis we kept on at presentation was obviously we kept carcinoma gallbladder more than benign condition because there was a mass that was seen and there were dense adhesions in this patient, and because of the higher incidence of gallbladder cancer in North India, and she is of the age of the patient is around 50 to 60 years, and she gave a short history of 3 months with right upper quadrant pain, and there was a history of previous abandoned exploration to gallbladder mass with adhesion. So we kept carcinoma gallbladder as a first diagnosis. What are other benign possibilities that we thought was that chronic cholecystitis being a possibility because she was found to have gallstone disease. Other one is xanthogranulomatous cholecystitis and adenomyomatosis. The reason we thought of benign etiology at this point is that there was no history of loss of appetite or loss of weight and there was no history of jaundice. So coming to the rare differential diagnosis over here, malignancy could be a squamous cell carcinoma gallbladder, papillary carcinoma, neuroendocrine tumor or lymphoma, benign condition, inflammatory polyps, biliary papillomatosis, IgG4 disease, and as faculties I mentioned, it could be a tuberculosis of gallbladder. So how to proceed in such a case? So we decided to review the previous investigation that the patient has come to us with, and also discuss with the surgeon who has operated previously. Even though there was no records available, patient gave us the phone number of the doctor who has previously operated on her. We decided to get a routine labs and confirm diagnosis with an imaging and send tumor markers and to get imaging done. So we reviewed the previous reports that the patient came to us. This was an ultrasound abdomen that was done outside on 21st of July. Over the report, they mentioned that the liver was normal. There was no liver mass, or there was no change in normal. There was normal homogeneous echo pattern. The gallbladder was moderately distended, and the gallbladder wall was thickened up to 5 mm in the neck and body region. Multiple dense echogenic foci are appearing within the dependent part of gallbladder. Mostly they were consisting of sludge. There was giving the impression of chronic ulcerative cholelithiasis. With this impression, the surgeon investigated the patient with a routine Waldorf investigation, which was within the normal limit. The CPC showed a hemoglobin of 12. With a platelet count of 1.3 lakhs, KFT was within normal limits, and LFT was also within the normal limits with a total bilirubin of 0.6. ALP and GGT, ALP was slightly elevated, 151. GGT was 38 at the upper limit of normal. Other investigations, OTPT, were within the normal limits. So we called the operating surgeon over telephonically. He told us intraoperatively he found a gallbladder mass with dense sedation, and these sedations were present between the mass, duodenum, and hepatic flexure of colon. And because of the same, he had converted the surgery to open. However, on open also, he found that there's a hard mass was palpable at around 4 cm. And because he was not experienced hepatobiliary surgeon, he decided to abandon the case and send the patient to highest center after discussing with the patient relatives. He had not taken any biopsy at this point. He had just explored and closed the abdomen and sent the patient to higher center after further management. So we evaluated the patient over here with the routine investigation that was done. Over here, the hemoglobin, a similar picture of investigation was shown with the hemoglobin of 11.6, differential count, platelet count was 2.1 lakhs, bilirubin was also in the normal range, LPGGP was similar. Coming to the ultrasound abdomen that was done over here, ultrasound abdomen showed a liver of 14 cm with a grade 1 fatty liver. The gallbladder was distended with a few calculi. The largest was measuring around 8 mm, and there was irregular wall thickening in the neck and body of gallbladder. The maximum thickness was around 7 mm. So we decided to further evaluate the patient. In the tumor markers that we sent came out to be CA99 levels was elevated with 1100. The tumor markers was CEA level was 2.3, which was in the normal range between 0 to 5. So we decided to get a further investigation patient, and we got a PET CT done for this patient. So this is a CCT done along with the PET CT, which showed there's a heterogeneously enhancing lesion at the gallbladder fossa, and there was loss of fat planes with the adjacent liver. However, there was maintained fat planes between the duodenum and with the hepatic flexure of colon. These were the similar findings on the PET CT imaging. PET CT imaging showing that there was a PET avid lesion that is present in the GB fossa. This lesion there was having separate from the hepatic flexure of colon and from the duodenum. This was the PET report that was given. There was an FDG avid irregular wall thickening of around 1.2 centimeters with an SUV max of 7.4, involving the fundus and body of the gallbladder, closely abutting the adjacent liver parenchyma, with loss of fat planes in the segment 4B and 5 of liver. There was faintly FDG avid periportal and portocaval lymph nodes present. No other abnormal hyperactive focus was present inside the body. We got CCT abdomen thorax done over here. I called the radiology resident to discuss in detail regarding the CCT findings.
Very good morning, everyone. In short, we have a 50-year-old female who presented to us with a vague abdominal pain and intraoperative findings being dense adhesions near the gallbladder fossa. And we further proceeded with the contrast-enhanced CT scan of thorax and abdomen, and these are axial sections of abdomen. And we are moving in caudal direction now. We see a well-distended gallbladder here, and we see a symmetric, irregular thickening in the fundus and also in the proximal part of the body of the gallbladder. And this thickening, it is heterogeneous in appearance on post-contrast scans, and also here we can see it is showing loss of fat gains with the adjacent liver parenchyma, and there is also species infiltration into the adjacent liver parenchyma. And also there is extensive fat stranding around the gallbladder, which explains the dense adhesions that the surgeon have found intraoperatively. And also this thickening, it is not extending till the neck of the gallbladder, and it is also not involving the cystic duct. And also the extrahepatic biliary tree, the CBD, all of these were normal. And the rest of the liver parenchyma, it is also normal. And we do not see any significant lymph nodes in the pericholecystic region, in the periportal region, as well as in the retroperitoneum. And the retroperitoneal organs, the bilateral kidneys, pancreas, they appear to be normal. And on moving more caudally, we see normal small bubble loops and normal large bubble loops. And we do not see any deposits in the omentum or in the mesentery. And the patient is hysterectomized for fibroids, so we do not see any uterus here. But there are no mass lesions in bilateral adnexa also. Coming to the thorax. There is no significant abnormality in the mediastinum except for very few subcentimetric lymph nodes. And we do not see any pleural effusion or any pleural deposits or malignant soft tissue nodules in bilateral lungs. On HRCT images of the lungs, we see ground glass opacities and few consolidations in the basal segments of the right lower lobe as well as in the right middle lobe. All of these, they indicate active infective changes. So, summarizing, we have asymmetric, irregular, heterogeneously enhancing thickening seen in the fundus as well as in the proximal part of the body of the gallbladder. It's a spacious infiltration into the adjacent liver parenchyma and adjacent pericholecystic fat stranding with no significant locoregional lymphadenopathy. And the first possible differential in this case, suspicious infiltration to the liver parenchyma would be a malignancy of the gallbladder, that is carcinoma gallbladder. And also we can consider three other possibilities like focal xanthogranulomatous cholecystitis, focal adenomyomatosis, and also focal chronic cholecystitis, which is very rare because chronic cholecystitis, it usually presents in diffuse form. There would be diffuse thickening of the gallbladder wall, and the one most probable differential, benign differential we could consider would be focal xanthogranulomatous cholecystitis, because it can also have pericholecystic fat stranding, and it is similar to GB carcinoma in this way, because it also has lymph nodes, it also has significant enlarged lymph nodes, but in this case we do not see any enlarged lymph nodes, and it is very difficult to differentiate it from carcinoma gallbladder on a CT scan. So in this case our first differential would be a carcinoma gallbladder. Now, further management will continue by Dr. Mithul.
So coming to the summary of CCT, abdomen and thorax, there were asymptotic enhancing thickening of the fundus and body of the gallbladder, measuring around 11 mm in thickness, and there was loss of flat planes with the right lobe of liver, segment 5, and there was ellipent flat planes with the first part of duodenum. The hepatic artery and portal vein were free from the lesion. There was no infiltration into cystic duct, and liver and other structures were within normal limit. So we decided to perform surgery for the patient. Patient was known case of diabetes mellitus, her sugars were controlled in hospital, and following which she underwent extended cholecystectomy and a GA on 19th of October. Intro findings were showing that there was no peritoneal, mesenteric or ventral or hepatic deposits. There were no free fluid. The gallbladder was contracted. A firm palpable mass of 3 into 2 centimeters was present in the fundus of the gallbladder with adjacent liver parenchymal infiltration. The right hepatic artery was closing in close proximity to the cystic duct region. However, it was separate from the tumor. There were no enlarged intra-aortic cable or hepatodural nodes that you see. Intraoperative cystic stem margin that was frozen came out negative for malignancy. So these were the intraop pictures that we had post dissection. Here, if you see over here, there's a gallbladder bed from where the gallbladder is able to put with the.
Use the cursor or the pointer.
So if you see. So if you see over here, I have the pointer. So if you see over here, this is the gallbladder fossa. The gallbladder fossa, after taking out a wedge of liver, central liver, along with the gallbladder. These are the portal structures. This is the right hepatic artery that has been looped and kept. This is the CBD, and this is the portal vein, and this is the left hepatic artery. This is the duodenum. These are the this is post-surgical photograph. This is a specimen of the removed specimen. So the post-operative course of the patient, we removed the engine folies on day 1. Patient was orally allowed a liquid diet. The diet was escalated to normal diet by day 3. Surgical site infection was noted, which was managed with regular dressing and flushing. Patient was discharged on day 5. The only complication the patient had was a surgical site infection, which was of grade 1 chlamydia classification. So coming to the histopathology specimen, the histopathology specimen. I'll just give the specimen. Okay. I'll invite the radiology, pathology resident to discuss in detail regarding the findings from the list.
Good morning, respected faculty members and dear colleagues. I'll be discussing the histopathology part of this discussion. Initially, we received a cystic duct margin for frozen section, which was given as negative for malignancy, and after that we received a radical cholecystectomy specimen along with the retroportal and aortocable lymph nodes. Provisionally, on the CECT and PET-CT, they have thought of a likely neoplastic lesion. Now coming to the gross examination of the specimen, the intra-frozen section for cystic duct margin was given as free of malignancy. After that, the radical cholecystectomy specimen was received, which measures 6.7 into 5 into 3 centimeter, in which the gallbladder measures 3 centimeter in length. Along with that, retroportal and aortocable lymph nodes were also sent. On examination, the outer surface of the specimen was irregular. Normally, a gallbladder will have a smooth glistening surface, but in this case, it was irregular. Might be due to the dense adhesions. On serial sectioning of the specimen, the gallbladder wall was found to be thickened with a maximum thickness of 0.4 centimeter, and multiple cholesterol stones were identified in the lumen of the gallbladder. The adjacent liver bed shows grey white area involving the wall of the gallbladder, which measures 1.5 into 1.5 into 1.2 centimeter. It was at a distance of 4 centimeter from the cystic duct margin, which was the only surgically resected margin. Now looking at the gross picture, we can appreciate the. So in the gross picture, we can appreciate the diffuse thickening of the gallbladder wall, and we can also appreciate the multifaceted yellow-colored friable stones, likely the cholesterol stones in the lumen of the gallbladder, and we can also see the grey-white lesion, which is seen to be arising from the wall of the gallbladder and involving some part of the liver. By looking at this, we first thought of a malignant etiology, and the diffuse thickening of the gallbladder can be seen in some inflammatory conditions also, like xanthogranulomatous cholecystitis. TB can also present like this, sarcoidosis can also present like this, and adenomyomatosis of gallbladder can also present like this. Now coming to microscopic examination, The lining epithelium of the gallbladder was mostly unremarkable with a slight denudation of the mucosa, and the lining epithelium was non-dysplastic. So at this point we almost ruled out adenocarcinoma of the gallbladder. Now coming to submucosa, there was multiple nodules and areas of dense fibrosis which was arranged in storiform pattern which represented fibroblastic proliferation, and there was also dense lymphoplasmacytic infiltrate along with histiocytes. There was also serositis noted which can explain the dense adhesions around the gallbladder. The adjacent liver wedge also showed some similar lesions focally. As we can see here, the lining epithelium of the gallbladder is absolutely normal. There is no dysplasia apart from slight denudation of the mucosa. In 10x power, we can see the lining epithelium and multiple nodules in the submucosa. This is one nodule, this is another. Now zooming in, we can appreciate a single nodule here. Now zooming more into the nodule, we can see the inflammatory cell infiltrate, and intermix between them is the fibrosis. The pattern of fibrosis here is characteristic storiform pattern, as we can see the spindle cells arising from a center and radiating in all directions, giving the appearance of spokes of a cartwheel. This is the characteristic storiform pattern. This pattern of fibrosis was enhanced on Vimentin staining. Now coming to the lymphoplasmacytic infiltrate, the inflammatory infiltrate comprise mostly of lymphocytes and plasma cells. The lymphocytes can be identified by a small round cell with a hypochromatic nucleus and scanned cytoplasm. These small cells are lymphocytes, and the a little bit larger ones are the plasma cells with an eccentrically placed nucleus and an eosinophilic cytoplasm pushed to one side. So the inflammatory infiltrate comprise mostly of the lymphocytes, plasma cells, and few histiocytes. Now looking at the microscopy, first thing we ruled out was malignancy, and keeping view of the diffuse thickening of the gallbladder, we kept the differential and the specific microscopic feature of storiform fibrosis and lymphoplasmacytic infiltrate. The first differential that we kept was IgG4 related disease, and also due to the presence of histiocytes, we kept granulomatous pathology as a second differential, but in fact there were no granulomas seen. The common granulomatous pathology can be seen is TB, xanthogranulomatous cholecystitis, and sarcoidosis. The classical picture of TB is a presence of caseating epithelial granulomas and giant cells. In xanthogranulomatous cholecystitis, we see past positive collection of foamy histiocytes, giant cells, in a background of chronic inflammatory cells. In sarcoidosis, we see non-caseating epithelial granulomas. In our case, we didn't see any granulomas. Another differential that we kept was inflammatory myofibroblastic tumor, in which we see spindle cell proliferation with mixed inflammatory cell comprising of lymphocytes, plasma cells, neutrophils, and even eosinophils. There was also increased mitotic figures. And there is also mild to moderate pleomorphism in inflammatory myofibroblastic tumor. In case of adenomyomatosis of gallbladder, we see cystically dilated glands and smooth muscle proliferation in the wall of the gallbladder, which was not seen in this case. So after looking at the microscopy, the primary report that we gave was a possibility of IgG4 related disease which cannot be ruled out. The aortic cable and retroportal nodes which were sent together showed features of reactive lymphoid hyperplasia, and we advised ISC for Vimentin, IgG4 and CD68, keeping in view of IgG4 related disease and granulomatous diseases. In ISC, the Vimentin stain was positive among the proliferating fibroblasts, and unfortunately the IgG4 came to be negative, and CD68 was also negative, ruling out the histiocytic lesions. After ISC, the addendum final report that we gave was suggestive of IgG4 related disease, which was according to the revised comprehensive diagnostic criteria for IgG4 related disease, which came in the year 2020, and we further advise correlation with serum IgG levels. Any doubts at this stage?
Carry on.
The staining was negative for
Yeah.
IgG4 disease. Still,
Yeah,
considered.
I'll come to that, sir. It is given in the criteria, I'll explain.
And ratio was also not been done of the IgG4 cells. And
So the IgG4 was negative, so the ratio will be.
So you are sure that it was not a myofibroblastic tumor?
Yes, sir.
You're sure?
Yes, sir. Now coming to the discussion of IgG4 related diseases, this is Dr. Vikram Deshpande, an Indian doctor who has done pioneering work, and he has published multiple national and international publications on the subject of IgG4 related diseases. So, and I have also included one of his articles as a reference. IgG4 related disease is a newly recognized fibroinflammatory condition characterized by several features, like a tendency to form a tumor-like lesion at multiple sites, a dense lymphoplasmacytic infiltrate-rich IgG4 positive plasma cells, presence of storiform fibrosis, and elevated serum IgG4 concentrations. The typical history of the patient is that he's a middle-aged to elderly man. The male to female ratio is 3:1, in contrast to other autoimmune diseases where the male to female ratio is 1:9, and there is no reports of genetic susceptibility as of now in case of IgG4 related diseases. The histological appearance is similar for all organs except for some minor changes. It is a multisystemic disease. There are three key histological features in case of IgG4 related disease. The first one is dense lymphoplasmacytic infiltrate, in which the majority of the cells are small lymphocytes, and in that also predominantly the T helper cells. The plasma cells are seen intermingled with varying numbers. Occasionally we see germinal cell formation, and scattered macrophages can also be seen along with eosinophils. The characteristic pattern of fibrosis seen here is storiform fibrosis, where the spindle cells, those are the fibroblasts and myofibroblasts, are seen radiating from a center. One thing to keep in mind is the storiform fibrosis in IgG4 related disease is patchy in distribution, so this can easily be missed if we do needle biopsies. And this type of fibrosis predominates in a long-standing disease, and this type of fibrosis is usually absent if the lacrimal glands and lymph nodes are involved. So in these two lesions, in these two locations, we see more of lymphoplasmacytic infiltrate apart from fibrosis. The third histological feature is obliterative phlebitis. It is the partial or complete obliteration of the medium-sized vein by lymphoplasmacytic infiltrate. The LP infiltrate is seen transmurally and also into the lumen. Elastin stains can be helpful if there is the marked obliteration of the vessel wall. In lung lesions and autoimmune pancreatitis, apart from phlebitis, we also see arteritis, but it is very rare. So this is a picture of obliterative phlebitis. We can see the obliteration of the lumen of the vessel wall, and there is marked lymphoplasmacytic infiltrate all around the vessel wall and also into the lumen. There are few histological features which are found to be inconsistent with the diagnosis of IgG4 related diseases, like the presence of epithelioid cell granulomas and giant cells almost rules out IgG4 related disease, and similarly prominent neutrophilic infiltrate and necrosis is also not seen commonly. Presence of arteritis is considered atypical, and the fibrosis pattern of acellular keloidal like fibrosis is also atypical. So how do we do quantitative assessment of IgG4 positive plasma cells on immunohistochemistry? First thing we count the number of IgG4 positive plasma cells. We count those cells in particular areas called hotspots, where we see diffuse staining of the IgG4 positive plasma cells. In other conditions where there is increased plasma cell infiltrate, the IgG4 staining is patchy, but in this case we have diffuse staining, for the number we have cutoff which varies from organ to organ. Like if lacrimal gland is involved where we don't see any fibrosis, the cutoff of more than 100 per hyperfill is considered, and also the type of specimen, like in needle biopsies, the cutoff is less when compared to the specimen. And like in case of bile duct and gallbladder, a cutoff of more than 50 per hyperfill is considered. The ratio of IgG4 to total IgG is considered to be more sensitive compared to plasma cell counts. The ratio of at least 40% should be present irrespective of the organ involved. And other methods like flow cytometry for IgG4 positive plasma cell can also be done. The newly biomarkers are FOXP3 positive regulatory T cells and IHC for type T helper 2 type cytokines. The diagnostic terminology used by the pathologist. We use three diagnostic terminologies. The first one is histologically highly suggestive of IgG4 related disease. In this, any two of the following histopath features should be present, like the dense lymphoplasmacytic infiltrate, fibrosis in stolliform pattern, obliterative phlebitis. Along with that, there should be IgG positive plasma cells according to the organ, and the ratio of IgG4 to total IgG should be more than 40%. And in majority of the cases, all these criteria are fulfilled, but in a minority of the cases, like in our case, the ISC and serologic criteria is not met. So in these cases, the histopathology is the defining character. The second terminology that we use is probable histologic features of IgG4 related disease. In this, we have three scenarios. The first one is only one histopath feature, that is mostly the dense lymphoplasmacytic infiltrate is present along with the required number of IgG4 positive plasma cell counts. And in case of needle biopsy, we don't use the term suggestive, we give probable histological features. And in few sites like meningeal and cutaneous diseases, as there is limited data available, we use the term probable histological features. And addition to this, there should also be serum IgG4 or more than 135 mg per deciliter present, and evidence of other organ involvement by radiological examination. The third terminology that we use is insufficient histopathological evidence. In this, the above two categories are not fulfilled, and this might be due to the sampling artifact and the effect of previous therapy and progression to fibrotic phase. Coming to serology, the high IgG4 concentrations are neither specific nor sensitive for the diagnosis of IgG4 related diseases. Like in one study, there was 20% of the patients with type 1 autoimmune pancreatitis had normal IgG4 concentrations, and in another study, 22% of the patients who did not have IgG4 related disease had serum IgG4 concentrations higher than twice the normal. In fact, the ratio of serum IgG4 and total IgG of more than 10 is considered more specific when compared to isolated IgG4. And monitoring of serum IgG4 concentration seems to be useful in assessment of the disease activity in some patients. And serum IgG4 concentration declines after glucocorticoid treatment in some patients. This is one paper which gave the revised comprehensive diagnostic criteria for IgG4 related diseases in the year 2020, and we have used this criteria for the diagnosis. This criteria included three items. The first one is clinical and radiological features. I have highlighted in red that we found in our case. One or more organs which show diffuse or localized swelling or mass nodule characteristic of IgG4 related disease. If a single organ is involved, lymph node should not be included. In item 2, we have serological diagnosis of serum IgG4 levels greater than 135 mg per deciliter, which was also increased in our case. It was in thousands. And item 3, we have histopathological diagnosis, in which there should be two criteria fulfilled among the following three. The first one is dense lymphoplasmacytic infiltrate. The second one is ratio of IgG4 positive plasma cells to total IgG of more than 40%. And third one is typical stolliform tissue fibrosis. So in our case, there was a mass in radiology and the serum IgG4 levels were elevated, and two of the three histological criteria were fulfilled. So a diagnosis of the definite IgG4 related disease was given according to this latest criteria. There are some non-IgG4 related diseases in which we see elevated IgG4 positive plasma cells, like in inflammatory conditions like this. Xanthogranulomatosis cholecystitis also comes in here. And in some lymphomas of low grade B-cell lymphomas, extranodal marginal zone lymphomas, few follicular lymphomas, we can also see elevated IgG4 positive plasma cells. In cases of malignancies, the IgG4 positive plasma cells infiltration is usually patchy, and there is obviously absent histological features. The take-home points are radiologically and grossly the lesions in IgG4 related disease can mimic malignancy. The inflammatory lesions can look metabolically hyperactive on PET scans, and needle biopsy should be avoided in diagnosis of IgG4 related disease, and there is absolutely no role of FNAC and cell block preparations in diagnosis of IgG4 related disease. Cases where ISC and serologic criteria is not met, histopathology is the main definitive criteria to be considered. ISC and serological criteria alone has got no significance. There should be histopathological features present. And one thing I want to add is, in ISC we use clone-specific antibodies. So if there is a slight change in the protein sequence of the immunoglobulin produced by the cells, the ISC will come negative. So ISC and serological criteria depends on the extent of the progression of fibrosis. So if the patient is presenting late, ISC can come negative in those cases. Thank you.